everyone. Scott, Jen, and I are excited to have you on. I'm sorry, give me 1 second. People are asking for the new link. Um, so today's presentation is being recorded for anyone who missed it, or if you want to share it with your colleagues, that is fantastic. We have two great cases that are being presented tonight. And then before we dive in, I know Scott wants to give a few little reminders. I also do want to let you guys know that you're going to be getting a survey from me, a short survey, just a couple of questions. We are planning what would typically have been a fall in-person meeting for you guys that we do every other year. Um, Obviously, this year, because of COVID, we're not doing it in person. So we're planning a virtual um, program that will take place most likely in March. And so I'm going to be sending you a survey. Typically, if we were doing in person, it's a day and a half in person, and we cover a variety of different hot topics and that sort of thing. So the survey is going to ask you regarding the timing. So do you prefer larger chunks of time, or do you want it spread out over multiple days in smaller increments? And then there'll be some questions related to topics. So just keep your eyes out for that. And please make sure that you respond so that we can take all of that into consideration when we plan. And so that's all that I have, Scott.
Great. I think Jen is on the line. I don't know, Jen, if you want to say a few comments first.
Welcome to everybody. I hope you can see me now. I had a little issue with Teams, but I refreshed, so hopefully you can see and hear me. We've got two great cases, and we'll try to get through these, giving plenty of time for the presenters to show all of the slides they've worked on, but lots of room and time for good discussion as well.
And Jen, I had mentioned before you got on that we're going to pick on the fellows first when we have those sort of stop points within each case. And then obviously feel free to ask questions, everyone on the line. And I'd mentioned we'll try to be mindful of those that are spending time with us on the faculty side and try to get everyone involved as time allows. So with that being said, Jackie, why don't you get started? Dr. Kocharek is a fellow with us at Hopkins. She is here for her first year of maybe more. She's going to present the first case, and I'll help moderate this, but with Jen Graves in the background, pushing us along in case we spend too much time on one slide.
Well, thank you for the introduction. It's nice to see everybody this evening. I am going to actually turn off my video in case there's a bandwidth issue. I don't know if you'll be able to see it during the presentation anyway, but I wanted to present this case, which I'm about to bring up shortly, just because I think it highlights some kind of ongoing trends in neurology at this point in time. So I hope you enjoy, and please let me know if you have any questions. Okay, can everybody see this okay?
Yeah.
Okay,
yep, that's great.
Okay. Okay, so this is just a brief outline of the presentation today. So classically, I'm just going to go through the history, physical exam, work up to date, at which point I think we could open up some discussion and then move on to differential, additional workup, diagnosis, and then further discussion of the case. So to begin, this is a 49-year-old female who presents for evaluation of an abnormal MRI of her brain. Her history goes quite some time back, beginning in 1999, where she had a sudden episode of vertigo, was referred to the emergency room by her PCP, who thought maybe she was having an ear infection. And so she was just kind of treated acutely there. Ultimately, her symptoms resolved. And then shortly after, she developed numbness and tingling of her extremities. At this point in time, there was a suspicion for GBS, and that was ultimately what she was diagnosed with. Her symptoms spontaneously resolved without treatment after about 4 months. And then she was pretty much back to her normal self until about 2001. She developed new migraines. And then in 2005, aside from the migraines, she was doing okay until she developed more numbness and tingling in her hands. Again, didn't really have a lot of other significant issues until 2014 or 15, where maybe she started to notice memory changes, forgetting why she went into the room for something, sometimes forgetting what she did the week before, just smaller details. And then in 2017, she developed some facial numbness and tingling that was intermittent, as well as some generalized weakness, maybe a little bit worse in her right lower extremity than her left lower extremity. And then in 2018 and 19, she developed increased headaches, even having trips to the emergency room and treatment for status migrainosus. And during this time, she also increased her Fioricet use as well. So moving on to further aspects of her history. Neurologically, she also endorsed some balance difficulty, but really had no significant falls or even near falls. She had some depression as well as some insomnia. And then systemically, the really only thing she reported was palpitations. Her past medical history did include bigeminy as well as an ectopic pregnancy. She had no known allergies. And then pertinent social history, she did have a 33-pack year history, works at a garden center. Family history, there was a history of dementia, stroke. Her father had cancer, and her aunt had a diagnosis of ALS. In terms of medications, she was really just taking Flexeril, Voltaren gel, Lunesta, and Effexor. And then in terms of prior surgery, she did have foot surgery in the past for high arches. And so part of her symptoms, particularly with some balance and maybe some of that weakness, she attributed maybe to some of her prior surgeries. And then she did have an AV node ablation as well. So moving on to her physical exam, her vital signs.
Excuse me, sorry, it's Bob Lissack.
Mhm.
I know I like the sort of old-fashioned Robert Lerb stuff, stop in between, if you don't mind. So when she had the paresthesias and the numbness, did she have any weakness with the so-called Guillain-Barré? And do we have any, I know it's a while ago, any proof that she actually had that?
Yes. So I will be getting to that shortly.
Okay.
But there was no clear weakness. It was really more paresthesias.
Okay, and one other question in the family, that dementia, at an early age, a close relative, or a 95-year-old grandma?
It did not appear to be early onset, and I
Okay.
think it was one of her grandparents. Again, it was a little bit fuzzy of a history.
Okay, thank you. Sorry.
No, that's okay.
Thank you.
Okay, so in seeing her in clinic, her blood pressure was 122/69, heart rate was 74, she was afebrile. Her general exam was really not that remarkable. Her neurological exam, however, she did have some horizontal nystagmus, although it was end gaze, a little bit of an ataxic pursuit. And then in terms of motor exam, she had 4+ shoulder abduction, finger extension, hip flexion, and dorsiflexion. And then sensory-wise, she had reduced light touch distal to the ankle in the left lower extremity and reduced vibration to the ankle in both lower extremities. Her gait exam, she had more of like a Trendelenburg type gait, and she had an impaired tandem gait and was unable to walk on her toes and heels. And in terms of her mental status and coordination, that was unremarkable. But her reflexes did reveal. So in the upper extremity, she was hyporeflexic. In the patellar reflexes, she was 2+, and then at ankles, that was absent. So I just wanted to talk a little bit about part of her work up to date, and then I figure we can discuss potentially localization. So in terms of her work up to date, again, this is spanning over quite some time, but she did have serum workup for Lyme, syphilis, HIV, she had an ANA, and SEDRA. All of that was unremarkable. She also had some evoked potential testing. So brainstem auditory evoked responses were tested, and she had the somatosensory evoked potentials as well, and those were within normal limits. She had an EEG that was unremarkable. She had an EMG and nerve conduction study that was unremarkable. She had a sleep study that revealed just idiopathic hypersomnolence. And she did have even Notch3 testing, which was negative. Her CSF results. Yep.
Jack, Yeah, hi, Elliot Froman here. Obviously, you know this case intimately and very well. You might just want to mention, based on her clinical semiology and then throwing in the notch, just for some of the students and residents, we've now been added in recent months by younger and early stage trainees. So maybe you could just give a little perspective on throwing that in, and based on some of the semiology you've told us about this patient's clinical history.
In terms of just
why relevant? We threw it in. Why would that? I think it is, but why the notch 3? We throw it in and we're running right through it. But there are, again, trainees who I think may be scratching their head and saying, why was that done? Yeah,
absolutely. So just in terms of general workup, so serum testing for potentially treatable causes, also for an autoimmune cause. So there's infection when we think about differential, which again, we'll get to shortly. But we think about all sorts of causes, vitamins, is it infectious, inflammatory? Is there a vascular cause? Is there another autoimmune process? And then we always also think about potentially more sinister causes too, like such as cancer. And then also there's always genetic causes as well. And I think just to put the notch 3 into perspective, which is commonly tested on boards as well. So CADASIL is one of those disorders that can present with migraine, stroke-like symptoms. You can get abnormal brain MRI changes as well. So in kind of talking about the workup so far, she's had migraine, she's had numbness and tingling, although it doesn't sound terribly focal in nature when she was describing it. Could it be concerning for a stroke-like symptom? Potentially. And so that was tested. And again, she was just having these other symptoms as well. So EMG nerve conduction study, whenever we think about Guillain-Barré or paresthesias, we want to see if there's a peripheral cause or if there's any abnormality on EMG nerve conduction study there too.
Exactly.
And same thing with,
You're wonderful. And I think just to put in perspective for Bob Lissak's comment about, cognitive dysfunction, was it precocious or was it, advanced age related? So the other part about your very nice history that you put together in terms of the history about, very, active headaches, migraine, talk about non-specific white matter issues. It's temporal, could be other places. But the other issue is, again, precocious cognitive complaints. And, you got to work it up and decide, okay, what are we dealing with there? Is it depression? Is it something else? But those are all really great points. And that may have been what Bob was getting at. And the only thing I would add is years ago when I saw some of these original cases, we know there's an association with hyperhomocystinemia when they are notch or have CADASIL. And of course, now we have CARASIL as well, a recessive form. So anyway, beautiful description. That's all I wanted. I just want to make sure that the students saw the perspective and putting this into the light of just running through these tests, and they're relevant. But I think that's very helpful for them.
Yeah, sure. And then I think since everything was pretty much unremarkable, as I've mentioned before, I think the most kind of helpful test result that we have are her cerebrospinal fluid testing. And so that did reveal these are the most pertinent findings, and it did reveal 1 white blood cell, 0 red blood cells, elevated protein of 85, and then oligoclonal bands were negative, and her IgG index was also within normal limits. And for students out there too, when we're thinking about inflammatory profile, or if we're here about white matter disease, and we're oftentimes talking about multiple sclerosis. And so we always look for an inflammatory profile of the CSF, maybe a lymphocytic pleocytosis, so elevated white blood cells, maybe an elevated protein, not always. Oligoclonal bands as well can be positive or negative in inflammatory disorders. And then IgG index can also be elevated.
And so, Jackie, with all that being said, just in the interest of time, maybe we can open the floor up to the fellows in terms of localizing sort of where the problem may be based on, everything that Dr. Froman had mentioned, the questions by Dr. Lissak, and then your exam, which I think is probably really informative. I don't know if you want to go back to your exam so everyone can see. So for the fellows.
One last thing, I think, Scott, I don't want to interrupt, but just Jackie has done such a gorgeous job in the systematic and moving through it and quickly. I just want to go back to the CSF for 1 second, because she very nicely talked about the items and issues that we think about that we haven't identified. But one piece of data here that's identified as the so-called cytoalbuminergic dissociation, that we have a somewhat elevated protein and few to no cells. And that can be extremely important and informative too, particularly in those disorders like AIDP, or acute inflammatory demyelinating polyneuropathy, or CIDP. And there's not a very high protein, but there is that dissociation here. And that's not in any way specific, but it's along the line of the question that Bob was asking: was there really evidence, for Guillain-Barré? This doesn't prove it, but it's certainly along that spectrum to see that cytoalbuminergic dissociation. Of course, one of the exceptions would be in HIV. Somebody with early HIV who has Guillain-Barré doesn't necessarily have cytoalbuminergic dissociation. As you know, they have high protein and can have a pleocytosis in HIV early on, as well as with CIDP in early HIV. Okay, I'll be quiet now. Thank you, Jackie. That was a great setup, and I appreciate you presenting that data.
No worries. So like Dr. Newsom said, I think it would be interesting to hear what maybe some of the fellows think about localization at this point based off of the exam, and I'll put that back on the screen.
I think you have to call on people. Do you know those fellows? They're out there. Just call on them. Yeah. We're all here together. We're all fellows. I'm a fellow. Newsom's a fellow. Jackie's a fellow. We're all fellows.
That's right.
I actually don't think I can see the participant list right now in my screen.
Yeah, I think we've changed the platform. I just see letters. Like I see, well, some of them I see names. I see Jen Graves. She'll always be a fellow and a student and everything. She's wonderful. But I see these others with letters but not names. Yeah. Hey, Doris.
Hi. So on your icons along the top, there is an icon that looks like two people. And if you click on that, it gives you the whole list of everyone. And most individuals have their first name and last name. And so I am certainly happy to kick this off. I see we've got Ryan and Sarah, both fellows who are on. Do either of you have any thoughts to share at the moment?
Again, we're talking about localization.
Yep.
I'm happy to share my thoughts on localization. One moment, let me get my camera going again so I can say hello to people. All right, very good.
Hi, Ryan.
Hello there. So just looking at the reflexes, that brings you first to thinking about a peripheral process. So anywhere from the nerve root more distally to the peripheral nerve. It's diffuse, so that's a little unusual. It would make you think about something like a CIDP, but nonetheless, she does have reflexes. So I think that it's particularly in her lower extremities at her patellae. So I think that makes it less likely. So it's kind of a mixed picture because she also has a headache that suggests a meningeal or vascular process. Other things, the reduced vibratory sense at her ankles, that can be myelopathy, or it can be a peripheral neuropathy. So I think it's broad. It sounds like a multifocal process. She's had more than one clinical event, it sounds like, as well. And can you remind me just briefly on what was the key clinical changes besides the headache?
So she had an episode of vertigo. Again, the duration isn't very clear, but it did resolve on its own. It was followed pretty shortly after, about a week or so, with the numbness and tingling in her hands and feet. And then she had just migraines over time, maybe a little bit of memory changes. And then she had some facial tingling at one point that she also noticed with some generalized weakness as well. And again, worsening migraines over time.
And then Ryan, can you comment on the motor exam as well? You mentioned peripheral and then maybe mixed patterns. What do you think about the motor exam?
So it has this, so if she has hip flexion and ankle dorsiflexion weakness, that suggests an upper motor neuron pattern of weakness. Same thing with finger extensors. So typically you expect in the upper extremities, if it's an upper motor neuron pattern of weakness, it would be extensors in the arms and then flexors in the legs. So there's that pattern that we appreciate there. And then you throw in the memory changes, the facial tingling, all that points to the, something going on in the brainstem and higher as well.
And hey, Ryan, even though they qualified by end gaze, let's give credit for the exam that in fact there was gaze-evoked nystagmus. End gaze doesn't militate against being significant, right? That could be leaky neural integrator nystagmus related to flocculus, so pulse step mismatch. And there's this idea about, I know non-specific with pursuit more than any other class of eye movements, but ataxic or is that cogwheeling, saccadic, not smooth, low gain pursuit. So those are two findings that I'd be interested in knowing more about how you're thinking about that. If you were at the bedside and say, oh yeah, I see the qualification, but really is velocity decreasing, gaze evoked nystagmus. The pursuit really is low gain, it's pretty jerky. Then you're thinking integrating that within the reflex changes, the sensory, the beta motor, memory, headache.
I agree. Jackie, can you clarify if this was true gaze evoked nystagmus?
It was primarily just on end gaze. We don't have much more detail in terms of that. But it did appear that it wasn't necessary. She was evaluated by other providers as well, and it wasn't picked up as much on their exams.
This was the description in the note you inherited.
Yeah.
Okay. All right.
Could I just ask one thing to the group? With the history of the surgery for high arches, does anyone want to make a comment on that? Because that may be relevant at some level.
And what about, was there any scoliosis on the general exam?
Not that we noticed.
Could I raise a point? The reason the Merritt Rowland system does gait as part of motor. And here you have a Trendelenburg gait, but you have, besides the upper motor neuron pattern, if you also can't walk on your toes, then you probably have both plantar and dorsiflexion weakness, right? And when you have 2+ at the knees, so normal on a 2 to 5 scale or even 2 to 4, absent at the ankles in mute toe responses, think about the conus and epiconus. There used to be keyboard questions. You have a patient who's got absent ankle jerks, mute to upgoing toes with normal reflexes, and what are the diseases? And it was sort of like, how many could you rattle off before they rang the bell and you went on to the next part of the orals? But and so B12 and Friedreich's and a few others, ALS, but of course they wouldn't have sensory. But epiconus and conus lesions are interesting. They can be flaccid actually, even though they have other upper motor neuron signs, but they often lose the ankle jerk, sometimes even the knee jerk. So it wouldn't explain the arms, and it certainly wouldn't explain the cranial nerves, the headache. And we heard, even though the higher cortical functions weren't mentioned in detail, there was a complaint of cognitive, which is why I asked about the family history, and Elliot brought up the Notch 3. So this sounds like you've got, brainstem, hemispheres, potentially spinal cord and or roots, and 1+ in the arms can be seen in normals, but that's a little down too, isn't it? So
yeah.
And not just for local,
very widely spread throughout the neuraxis.
Yes.
Not muscle necessarily, but certainly everything central and potentially roots.
Yeah, and not necessarily only localization, but if I could just jump a little bit, if you'll let me, from the standpoint of categories of disease, if you think about the combinations of some patients or conditions where there's both central and peripheral demyelination and maybe an admixture of some axonal components, then you think about disorders like metachromatic leukodystrophy, adrenomyeloneuropathy in a child, dysmorphology, Cockayne syndrome, Krabbe's. Of course, some people we've seen over the years who really do have had MS and CIDP. And Bob, you mentioned B12, which can be central, peripheral, demyelinating with axonal features. So I agree. I think Ryan's assessment was lovely in the sense that, he jumped on the reflexes, but he also didn't focus in one area. It's diffuse, features of upper and lower. So the other part of this is, how did these evolve over time? And, there are disorders where you can have central peripheral. The high arches, I don't think we ever got a clear answer on that, but raises the specter of, are we dealing with, again, a potential hereditary sensory motor condition? Obviously, we think about that. We look at, there are these various variants of Charcot-Marie-Tooth and an expanding, semiology of those, and the genetics, I think, partly solve that riddle, just like in the SCAs. But
which Thomas Varkey had actually mentioned that in the chat. Are we worried about Charcot-Marie-Tooth?
Yeah.
The high arches. So, but in interest of time, why don't we move to the MRI?
Okay.
Jackie.
Yes.
Yep.
What we're all here for. Okay.
No, we're here for you, Jackie, not the MRI. And so far, A plus, my friend, A plus.
So I'm hoping these videos work. If not, I do have some backup images, but this is the MRI brain. I'm showing the flare just because I feel like it's the most prominent here that we can see the abnormality. So this is going to be the axial flare. Let me go back here. And might pause a few. Okay. So I'm just going to pause at a couple of spots so people have time to kind of take it all in.
Mm-hmm. It has that look,
Yes.
It's abnormal.
It's abnormal.
Not only that, but if first thinking about, leukodystrophies, other things, where you get this sort of symmetry in somebody this age. But yeah, very nice.
Well,
Could you just do one thing?
Also, can you show a little bit of the lower cuts, Jackie, to see
the medullary pyramids.
The track effect on the pyramid.
Yes, you're right. Very low medullary. I was wondering about the pyramids that we went through. Right, stop right there. The ventral medulla. I was not sure, but it caught my attention. If you can arrow the ventral medulla at the level of the pyramid, little brighter on the left compared to the right. I'm not sure that you can move your arrow on that or not.
Oh, can you see it? Sorry, I thought you could see it.
No, I can't see the arrow. I see
no.
I see the
I'm pointing to it.
Oh, I'm sorry.
I'm sorry.
That's okay. But does everybody, Bob, is this what you are also looking at? This was the
Maybe
slide
I can.
that got my attention. It went
That's what I was looking for.
fast. Yeah, there you go. Oh, thank you, Jackie. Wow.
There it is.
There you go.
Perfect. Green
I don't know
circle.
that I'll be able to get rid of it now.
It works though. It'll do. We need it.
Okay.
And what about, so Sarah didn't get a chance to comment, I think, last time. So I don't know, Sarah, if you want to make a comment on the initial MRI that we're looking at.
Yeah, so I mean, certainly as we were coming up from the bottom and we kind of took that first shot where we stopped looking at, I think, both the temporal lobes. I know we had tested for Notch 3, but when I hear about, stroke-like episodes, migraines, and then I see involvement of the anterior temporal lobes bilaterally, I certainly think about that.
Mm-hmm.
I guess the one thing that I'm noting about this MRI is just the confluence and the involvement of sort of all of that subcortical area, sort of all the way down through the brain, but also that it's very symmetric. So when I think about differentials, inherited things, metabolic disorders, something that's more of a systemic process, or perhaps an overlay syndrome with central nervous system consequences. I think that makes a lot of sense with the exam we had, which I didn't think localized very clearly to one specific area, but it was much more diffuse.
Yeah, no, excellent. I see Mike Levy's on.
Yes.
Just curiosity with some of the disorders you treat. Can you see this imaging pattern with, let's say, NMO, anti-MOG-related disorders?
I'll be really short. No.
No.
Okay.
I'm morphology and individual lesions, I would say yes, like Sean Piddock's beautiful paper in what used to be called the Archives of Neurology years ago. You could see one of these, but I think, as Sarah was making a very nice point about the symmetry side to side, that would be exceptional. So I would agree with Michael on this one, that a piece, but not the pattern.
Perfect.
And I just want to do a quick time check. We have roughly 12 minutes left for this case, and she has about 10 more slides to go through.
Okay.
So I'm just going to wrap up quickly then with the imaging and just kind of summarize what everybody said. Everybody's made great points. So it's a confluent, you see confluent symmetric signal pretty much throughout the entire brain, with the exception that the cerebellum is spared. So a lot of the posterior fossa is spared. There was some signal change maybe in the lower medulla. And ultimately some of the occipital lobes were spared. So we have a symmetrical confluent pattern in both the subcortical and periventricular regions. That's pretty diffuse. And so moving on just quickly, I do want to show you additional imaging. So we mentioned before her reflexes, which I think is a big tipping point, that anytime you see overall, maybe there's a majority of hyporeflexia, and then you see a normal reflex, there's always a possibility that the hyporeflexia or maybe a peripheral process is masking an upper motor neuron process, which I think we saw both evidence for both on the exam. So, and just moving on, this is her imaging of her cervical spine. So this is on the left, we have the T2, regular T2, and on the right, we have a T2 stir. I do have a video here that I would like to show because I think you can see some of the abnormality a little bit better.
Yeah.
So you can see some posterior signal change, hyperintensity. Of note, both in the brain and spine, there was no contrast enhancement, no SWI or GRE changes. And so really it was just this mostly posterior kind of confluent signal abnormality of the cervical spinal cord. And there was a little bit of anterior signal change, but to be honest, I had a hard time seeing that as well. If we move on to her thoracic spine imaging, she also, again, here on the left, we have a T2, and then on the right, we have the T2 stir. And so you can see a little bit of this posterior signal change. Again, I'm sorry that my mouse isn't working, but you can see it a little bit better on the stir imaging where it's hyper intense. And again, it seems a little bit more confluent. So we mentioned some leukodystrophies, and I think moving on, I would like to talk about her brain. We kind of already mentioned we would be concerned about a potential genetic or metabolic or mitochondrial condition. And I want to move on now to talk about kind of her, well, I will show you actually. This is her axial of the thoracic. So it's dorsal and a little bit central as well. You can see
by the way, was there a pattern early on where arms were, there's central, arms were more affected than legs, that it sort of led the charge, legs followed, but arms seemed to be a complaint early on? Just thinking about the more central lamination.
Yeah, it was hands and feet. And then the weakness was more so in her legs, although over time she would notice slowly maybe some difficulty opening soda cans. But a lot of her symptoms were kind of more of an insidious nature later on.
Okay.
Would note, Jackie, on that axial, as far as down as you could go before the roots start coming out, the conus, there's a lesion there, all the way down.
Right.
All the way down.
It's not just central canal, it's skipping on and off.
Yeah, but it gets into the conus, epiconus. That was my point.
So for the fellows who have not participated as of yet, do any of you want to sort of shout out with what you know about the case currently? What may be the differential, this diffuse symmetric white matter disease, longitudinal extensive myelopathy, maybe superimposed neuropathy. Not very straightforward case. And I think, as Jackie mentioned early on, that as we have more people in the workforce seeing patients with white matter diseases, we may come across a lot of these cases. And, what do we do?
So, hi, this is Todd, a fellow with UCSD. I think just what we have is basically a picture of maybe combined central and peripheral, maybe demyelinating process. We don't have really a lot on the EMG, but still together with the high arched feet on exam as well. I mean, it makes you think more of like you guys already said, like a leukodystrophic process that affects the central and the peripheral. It affects both centrally and peripherally. I don't know if there were autonomic symptoms as well, which could also hint. And then, I mean, you already mentioned it. You would think of something like Krabbe's, metachromatic leukodystrophy, other leukodystrophies. So that would be kind of where I would be heading to. I don't know if there was HIV testing. That would be, of course, something you would get very early on, which sometimes it could affect, the same structures if it's advanced, but it's probably lower on the differential, but it's something to test for.
Yeah,
and then
no, absolutely.
And a female carrier with adrenomyeloneuropathy is unusual, but has happened. So with AMN and very long chain fatty acid oxidase deficiency. But to continue along your point, those were really great points. But the other question that comes up when you talk about metabolic, that's such a huge basket. So this is why our pediatricians usually, they sort of eclipse us and say, well, what were the amino and organic aciduria assessments? Because now we can sort of swing into full gear a whole sequence of different biochemical cascades, right? Lots of them. So at some point you do have to do some profiling because some of them can be indistinguishable.
Yeah.
Yep.
Dr. Rempe, I was going to ask, what would you like to do next to help with your differential?
Well, I think the main pressing thing early on in working this up is looking for treatable causes, both in the metabolic range, and of course also like HIV, but then like I mentioned, all the different like leukodystrophies. I mean, you can test for them all, like aryl sulfatase, and but usually at that point probably you would send out a genetic panel where you have those in there.
Yeah, no, I think that's a great point. I think at least how some people will approach these leukodystrophies is looking at the pattern on MRI. What areas are involved on the imaging? Is it more anterior, posterior? Is it diffuse like this patient? Is there spinal cord involvement or not? Are there other organ systems involved, which I think was mentioned previously? So that can help narrow down what you order, which I think is incredibly important because you can, spend thousands of dollars, in working these type of cases up. And so I do think the pattern is quite important. I think I saw Steve Galetta, if he's still on as well. I don't know, Dr. Galetta, if you, with your expertise and long-standing work in neurology, any comments on sort of the imaging patterns? Like, what would you think of in this particular situation? Like, if you had two tests that you would want to do.
Yeah, I thought that it looked like a metabolic disorder, adrenoleukodystrophy type of picture. And I would definitely want long chain fatty acids in this case.
Yeah, great. Jackie, and
by the way, Jackie, you didn't mention that this gal was eating about 100 zinc tablets. She felt so good. Not that this is a classic pattern, but Torge, beautifully underscored the emphasis on treatable causes, and we know about denture cream myelopathy and hyperzincemia dropping out copper. So I certainly would want to look at the copper, even if the copper was very low, I still have to come back to Galetta and say, okay, what else have you got for me? It's like showing an MS patient they got B12 deficiency, and they say, oh, so I don't have MS. And you go, no, you have MS, but you also have B12 deficiency. So when you start looking at these metabolic treatable issues, you got to make sure that you don't stop on the first treatable derangement you find. You got to keep going and make sure that you've identified and covered the landscape, and especially what's most responsible for these really dramatic, conspicuous images. Which, congratulations for presenting this.
Just one quick comment about the pattern, Scott. We have a patient who we try to get to you guys, but she didn't have the right insurance. So please, everybody, go out and vote and get these. Never mind. I sound like Bernie, and I sound like Bernie. But the our chief of neuroradiology, and I think Mara Kirk, is on one of our former chief residents who's with Amit now. The older the onset of the patient, Emmett Zach says, is you have to be very careful about the pattern. So we think about posterior for adrenal leukodystrophy. Admittedly, you can have a manifest carrier in a woman, but the older the onset, the less you can hang yourself on the pattern of which one of the dystrophies. So the older Alexander's looks very different in young kids than in people who start in their 20s. So you're right. If you catch it early and it's classic, it's classic. But when they get diffuse like this in somebody of this woman's age, sometimes it doesn't help as much as you'd like. That's just something that our chief of neuroradiology, who's very experienced, sort of
I
passed
think
on.
that's a really great
that's a
point.
really
But
good
the
point.
reciprocal is about childhood diseases, metabolic and otherwise, that present in age-advanced individuals with dementia or cognitive dysfunction. And again, I go back to the very good fellow at UC San Diego, obviously with Jen Graves. And you got to raise the specter about treatable issues. And one of those, we were examining a patient in the exam room a number of years ago and felt this tendon xanthoma, and a guy was complaining of cognitive dysfunction, and it raised the specter. We made that leap from tendon xanthoma, cognitive complaints, to cholestanol, not cholesterol, cholestanol, and its treatment, chenodeoxycholic acid, for cerebrotendinous xanthomatosis. But this is just one of a spectrum of disorders, more common in kids, but can present with these kinds of features in age-advanced individuals, especially with cognitive deterioration. Urea cycle, Wilson's disease, all the things we think about with treatable causes. And then, you got to run the amino and organic acidureas. And I agree with Steve on the long-chain fatty acids. And you got to.
So Elliot.
So, Jackie,
Yeah.
what?
Elliot, and since we do have Steve Galetto on, what all do you think? We didn't get a lot of information up front in the initial history about the neuro-ophthalmologic exam, but one thing when I see these patients is I am very curious to know about optic nerve involvement and other neuro-ophthalmologic findings. Would that, if we were able to get our own good exam here, how would that influence differential?
Yeah, glad you brought that up. And for those listening who don't know, Jen Graves did neuro-ophthalmology at Penn with Galetta and with Laura Balser before she went to do neurogenetics and trial design and everything else at UCSF before UC San Diego. So Jen, for me, that's very important. This is the part of the exam that I think, people walk by, they say, well, get an ophthalmology consult. But the reality is you don't need special equipment. You need one piece of special equipment, and that is an experienced brain. And look, if I come to the bedside and I know what you're saying, this is like I'm talking to another analog of myself. I'm thinking, look, does this somebody have a leaky neural integrator? Is there really saccadic pursuit? Is there dysmetria? Would that raise the specter of a spinocerebellar degeneration? What are the other findings do I see? Is there primary position downbeat nystagmus? That would suggest that there's deep cerebellar nuclei, fastigial nucleus. That's the most common. Is primary position is downbeat. Why? Because there's such robust homolateral inhibition of same side vestibular complex. So, and more predominantly on that anterior canal afferents than posterior. So if you take it away, you get disinhibition, slow phase up, and downbeat nystagmus. But right, gaze evoked, centripetal, rebound nystagmus, saccadic pursuit, saccadic dysmetria. I would want to, and it, by the way, is this symmetric? Is there hypometric in one direction, hypermetric in the other? Probably not likely. This is not going to be contrapulsion or ipsipulsion. This is too symmetric. But
So Elliot, I thought you were going to say OCT.
Well, she's getting to that point. I was going movement, but the visual system is really both, right? It's afferent talking to efferent's copy. They're integrated together. Over 95% of the brain is going to be concerned with vision. So I would totally agree, not just looking at the eye movements, fundoscopic exam. I would want to get retinal photography, actually, to look at those optic nerves. Is there evidence of pallor? Is there a retinopathy? Yes, OCT for thickness layers. But I will tell you, for me, not just, getting layer thickness objective stuff, I would be more impressed with Jen Graves' eyes looking through an ophthalmoscope, or having Jen sit down and look at retinal photography more than just layer thickness, knowing what you know, Scott, and your group and our group and Jen's group and Galetta's group. We know all these neurologic diseases have an effect on changing the slope change of axons in RNFL or GC. But what you don't get from OCT is the brain behind Jen Graves' eyes that say, those optic nerves are not right. There's some black spiculed pigmentary retinopathy going on here. Those are the sort of things that the experienced eye looks at and captures, and sometimes surprised that, hey, did somebody not see this? The only way you know is you have to look. And so I would agree, this is such a huge part of the system. How can we not talk about what was the fundoscopic exam? Do we have photographs? Is there pallor? Is there retinopathy? Are there other features that suggest that there are peculiar features and abnormalities?
No, I agree. So Jackie, just to move
And
on,
just-
why don't you tell
yes.
us what additional testing was done?
Yes.
Yeah, I would just comment that it goes beyond the optic nerve. In adrenoleukodystrophy, you get optic atrophy. In cerebral tendinosis, you get a flower-like cataract. And in CADASIL, you get this unusual sheathing of the arterial vessel. So I think it goes beyond just looking at the optic nerve and retina and other parts of the eye that might clue you into the diagnosis.
And Galetta, there's always the hyperhomocystinemia with the kids that have iridonesis. It looks like they're a 75-year-old with shimmering, moving cataracts in their eye, or the intraocular lens, I should say, that replaced the cataract, but they don't. It's a funny oscillation that you see in kids with the hyperhomocystinemia, maybe because of the cystathionine synthetase enzyme deficiency in that part of the metabolic pathway that's dependent, by the way, on vitamin B6. But again, I go back, amino and organic acids would be extremely important in this as well. So great point, Steve.
I think that's a great transition. So just a note too, as we move on, is that the fundoscopy exam was normal. But I'm not going to go through the imaging because it was relatively unchanged. There was a little bit of extension of the white matter lesions into the posterior temporal lobes and kind of the inferior frontal lobes. Otherwise, the cervical spine was maybe a little bit less extensive and looked more multifocal this time around, but really it looked very similar. Same thing with the thoracic spine, very similar again. So this is just imaging of the cervical spine and then the thoracic spine. And so we did repeat quite an extensive additional workup. Some things were repeat, some things were not. So vitamin B12 was actually low, 151. Vitamin D was low as well. She had a pretty extensive autoimmune workup that was negative. Leukodystrophy, we did test for some enzymes that was negative. However, on her mitochondrial testing, she did have an elevated lactate and elevated alanine and glycine, which included the ratio. So in terms of, we did repeat the EMG nerve conduction study, and she ended up having on our EMG nerve conduction study a length-dependent demyelinating polyneuropathy. We did perform OCTs, which was consistent with optic neuropathy in both eyes. And so we ended up referring her, I think, as we already mentioned and discussed in the differential, at this point, it's a little bit out of our wheelhouse. And so we did refer her to genetics for potential whole exome sequencing with mitochondrial DNA, further leukodystrophy evaluation. And our specialist ultimately said, she had a mildly, maybe borderline low aryl sulfatase level, but not low enough to really consider it consistent. And then her demyelinating neuropathy was not very typical for leukodystrophy. A lot of times it's more axonal, and that maybe she'll need a muscle biopsy, which she has not had before. And she had a sleep study, which just kind of confirmed her her idiopathic hypersomnolence, and then physical and occupational therapy was definitely important in her case.
Did you say that she had very long chain fatty acids and
She had all of that. Yeah, she had a pretty extensive testing, and that was all negative. The only thing that really came back was the aryl sulfatase was a little bit low, but again, not low enough to be considered.
Yeah, because the AMN patients, that more males, but even in female carriers, will have a peripheral demyelinating neuropathy, but have also axonal features of a peripheral neuropathy as well. By the way, did you say what the homocysteine level was in her?
That was normal. So her extensive metabolic, everything was normal. Even some of the infectious Lyme, syphilis, which she even had in her spinal fluid VDRL, that was negative.
Was there a concern with the elevation? Could she have hyperglycemia?
And that was her glycine was normal. The only things that came back in terms of amino acids and all that was alanine. Well, I see what you're saying. Alanine and glycine, yeah.
I don't think it was high enough, Elliot.
Okay.
Yeah.
It was primarily the ratio that caught the attention for a possible leukodystrophy, not the actual
I think that the dog we're listening to has been added to the webinar since the recent transition in leadership, and that dog knows how to say in dog language, Elliot, stop it. And
move on.
And move on. I do recognize that sound.
She also did have repeat testing for Cadacil and even Carosil since it became available, and those were both negative as well. Wow. So just moving on, the most pertinent thing at this point is her undergoing the whole exome sequencing as well as a mitochondrial DNA screen. And it came back with a surprising result of a laminin alpha-2 related muscular dystrophy. So this is a congenital dystrophy, and I will say that the variants that came back were of unknown clinical significance. And so whenever we see this with gene testing, we always have to correlate it with the patient sitting in front of us and the phenotype and see if it could be consistent. And so just a couple words on the mutation. It is autosomal recessive, and she did inherit one from each parent. She did end up having compound heterozygosity for it. And so she ultimately, the laminin alpha-2 protein is part of the myosin protein. It's a subunit, and it's found in basement membranes of striatum muscle as well as in the nervous system. And you can get a deficiency or an absence, and that ultimately leads to the phenotype. So typically, the spectrum of disease is early onset is the most severe, and it's usually because of an absence. And then there's late onset, which could mean childhood or even older into adulthood. That tends to be more mild disease and more along the lines of a deficiency. And then interestingly, nearly all individuals, no matter the spectrum, have white matter abnormalities on MRI. That's including the brain. Spine is a little bit different, and it does not appear that there's really a lot of literature case reports involving the spine in this condition. However, I will say that the laminin alpha-2 is found throughout the central nervous system, including neuronal and glial cells in the spinal cord. So it's not entirely implausible. And so typically in the milder onset, so the early onset is pretty severe. There's respiratory difficulties, kind of the classic kind of congenital muscular dystrophy presentation with hypotonia, a lot of complications, delays in development. So with a milder form, typically they'll have an independent ambulation, most have a normal intellect, and then they can develop proximal muscle weakness with or without hypertrophy. And I think our patient had a mix of that. She had some hip flexion weakness, shoulder abduction weakness. And then MRI is typically diffuse confluent subcortical periventricular abnormalities, which you can see here on the right. Interestingly, if you get a biopsy in these individuals, their immunohistochemical staining is typically not revealing for a deficiency. That's usually what you're looking for, just because of the mild nature. So it may not be as helpful in terms of muscle biopsy and staining. And then EMG, you can find a demyelinating neuropathy. On EEG, often there's about 30% of patients that can have epilepsy, and typically it's correlated with malformations in the brain. And oftentimes those are actually in the more temporal-occipital areas, even though a lot of the white matter kind of avoids the occipital region. But it can be kind of like a migrational disorder that can lead to the epilepsy. And then muscle and skin biopsy, again, you'll see deficiency of laminin alpha-2. And then in terms of muscle MRI, you may see some edema or fatty infiltration.
And Jackie, I'll just point out real quick. So Elliot had mentioned this earlier about, don't stop when you find something that may be abnormal here, that's what was done. But also, she had very low vitamin B12, which could account for the posterior column longitudinal extensive myelopathy. I don't know if you guys had thought about that when you saw her, but again, just trying to think about what you're showing here. Spinal cord involvement, not clear whether it is related to this condition or not.
Keep going. Yeah.
The one thing I would mention is the homocysteine is normal, and homocysteine is not a specific elevation for B12 deficiency as MMA. So all of my patients, our residents and fellows know, we get the MMA because that is more specific for B12. Homocysteine, as Elliot pointed out, B6, folate, a lot of other things.
Yeah.
Great point.
And the MMA was also normal in her too, but it is a good point. I think it did come across our minds. It just wouldn't explain the anterior changes that were also noted as well. But it was mostly posterior column, didn't involve the lateral corticospinal tracts. But I definitely think, could it be also contributing to her paresthesias? It's possible. And so I agree it's important to kind of keep in mind other things that can be going on with individuals who do have a congenital condition, that it's not always related to their underlying condition. And I think that brings us to the management of disorders like this. So a lot of times it is supportive, but it's really important to keep in mind surveillance. Are there new treatments, new trials? Because I think as time goes on with neurogenetics, and the increased availability of whole exome sequencing and genetic testing, that we're going to be seeing this more often. We may even be seeing phenotypes because there are variants to each of these conditions. And right now, this individual has a variant of unknown significance, but there are 309 variants so far of this condition. So maybe we just haven't seen it enough in practice. And so just in terms of the LAMA2 specifically, supportive therapy, really multidisciplinary approach is best, and physical and occupational therapy are kind of mandatory mainstays for individuals. And then social work, particularly for the early onset, is really important too. And then newer treatments, keeping an eye out for new treatments. Right now there's mouse models and kind of studies looking in mouse and zebrafish about potential replacement of the gene or substitution of the gene, and maybe there will be new clinical trials. The interesting thing to keep in mind is that in these individuals, you want to avoid succinylcholine because it can cause potassium abnormalities, and like our individual who already has a conduction abnormality, which could be due to her underlying condition. There's always a concern it could provoke an arrhythmia. And then statins as well for potential for muscle damage has been recommended to be avoided in these individuals. And then ongoing surveillance. So we mentioned before, multiple organ systems can be involved in conditions like this. So really importantly, cardiac issues, to keep monitoring that regularly, seizures, respiratory difficulties, and other musculoskeletal changes. I think somebody mentioned scoliosis earlier, which is present, and you can get joint contractures as well, particularly with the earlier onset.
And Jackie, Thomas Varkey had asked, did you get a CT? Like CT of the body looking for paraneoplastic? I think
we did. I mean, primarily, primarily because it had been going on since 1999. We probably expect to see kind of expression of an underlying malignancy if that was in fact part of the cause. I think she did have a serum. Yeah, she had a paraneoplastic panel that was negative, serum paraneoplastic panel, but that was pretty much, I don't think we did a full body, CT or PET scan at that point, just given the pretty.
It's not just, Jackie, that you'd expect the cancer to show up, but the fact is that these are not chronic. These are subacute diseases in general. There are exceptions, but in general, they're subacute. Mm-hmm. This started in '99, unless you want to give it 3 different diseases.
Yeah, no. That particular kind of cancer by that point would be expressed as dead. So
dead, yeah, exactly.
New form of cancer called not cancer. Yeah.
Yeah, just for the fellows, I mean, the majority of the paraneoplastic related neurological conditions, you end up seeing or identifying the cancer within 5 years of symptom onset. That's sort of the typical teaching. I don't know if others on the line have seen it go beyond that, but at least the cases I've seen, it's within 5 years you identify the cancer.
Although she is that 33 pack year, so
sure,
not unreasonable to let it go through your mind. Certainly.
Yes, absolutely.
Yes. So kind of moving on to the main teaching points of this case, I think rare diseases can have rare presentations, and I think I touched on this just recently. So she already has a rare gene mutation, and then we don't know necessarily the phenotype, especially with the spinal cord involvement. So I think this could raise also the question, could she have this congenital muscular dystrophy, and then what are the chances like MS or NMO, or like we said, B12 deficiency could cause it too. But I think at this point, we're kind of more concerned about the potential for having spinal cord involvement of this mutation and the deficiency. And then in terms of just your primary assessment of individuals who come to your clinic, if you see multiple systems involved, peripheral, central, cardiac, she had bigeminy and arrhythmia, it should raise suspicion for mitochondrial or genetic etiologies. And then sometimes repeat testing is necessary for unclear diagnoses. So her first EMG, especially with that consideration of GBS, was negative. We repeated and it was positive. And that can kind of clue you in on a diagnosis as well. And then genetic testing, as I mentioned, is becoming more available. And so we may actually be seeing new spectrum of phenotypes, and it may clarify some of these variants of unknown clinical significance. And then long-term monitoring and supportive care for complications is a really important mainstay of therapy, or of care, of ongoing clinical care.
That's fantastic, Jackie. I just want to point your attention to Chris Holland. I think he asked a really provocative question in the chat about, ultimately, should we get whole exome sequencing if lactate pyruvate, urine amino acids, long chain fatty acids, and other targeted metabolic investigations still don't give us a reasonable answer? So what would you say?
There was actually a really great comment in one of the articles, and I'll go to my references. This first one, the update of the LAMA2 muscular dystrophy. So they mentioned that if you see a phenotype in your clinic, and first of all, they also mentioned that if you're suspecting some kind of muscular dystrophy, you should definitely get an MRI, because oftentimes, even not just LAMA2, which actually is a more common cause of the congenital muscular dystrophies, they do suggest getting an MRI. And if that's concerning, then definitely perhaps doing a targeted gene assessment if you're not entirely sure, or the phenotype's a little bit atypical for LAMA2 muscular dystrophy. They recommend doing a muscular dystrophy gene panel. And if it's really atypical, then you should probably just do whole exome sequencing. So in this case, it might be good to consult some colleagues, maybe in the neuromuscular clinic too. If you have somebody come in, maybe it's a muscular dystrophy, there's peripheral involvement as well, and kind of decide what their phenotype is most consistent with. And maybe that can help you kind of say, okay, let's do a more targeted gene assessment, let's do a panel, or let's do whole exome sequencing.
Just that EMG nerve conduction, if there were no conduction block, no delays and things like that, F wave and so forth, it sounds length dependent. That may go, that more what you see in dads, not that this is dads, but that actually goes to me much more with an inherited neuropathy.
Mm-hmm. Yep.
So you can check with Kornblath and see if I remembered correctly.
Yeah, I know we're running very low on time. We have another presentation. I just wanted to say, obviously, Jen, Scott, you guys run it, but Jackie, this is fabulous. And what I love about this is people will say, well, it's very minutiae. The reason why this is such an important case, and you did such a great job presenting, and why I would try to convince Zamville and others that this should be written. And that's because this is not just, okay, we found this unusual mutation, it's a mimic of other things. This is a mimicker of mimickers. So the pearls that could be in a case like this, you've already addressed this issue in terms of what's treatable, what's not, what makes sense, the time frame, for the evolution of this process, and when do you pull the trigger and look at, genome, assessment. A mimicker of mimickers is very important and very special. Many things cross the spectrum of your mind, including the idea that just finding something treatable doesn't mean that you're gone. So you keep going, which you did. So I think this is a very, very important, not only teaching case for the fellows, but I think an important principle to underscore for practitioners, for the pros, is that this is something you have to really slow down, take a breath, do this sequentially over time, systematically. And there's a time you have to go broader and then decide what do you do with this, which is why I think your endpoint about management and looking at trials and, keeping aware of what's going on out there, because others are, identifying these as well. But a lot of these patients like this are passed over and are just given bogus diagnoses. People don't know. And I think that's why this is so important. This is a great,
No, I agree with you. I agree with you, Elliot. Yep.
Great job.
Thank you.
Excellent. Thank you,
Excellent.
Jackie. Yep. All right. So moving on to our next presentation for tonight, we have Dr. Cruz and Dr. Varkey. And so Thomas, go ahead and share your screen, please. All right. Excellent.
And I'd like to just make a quick point, just in the interest of time and making sure we get through the whole case, that I think in looking at these slides, we could probably try to get up through the first 5 slides and then maybe take a pause there, if that works for you, Dr. Cruz and Dr. Varkey.
Absolutely.
Okay.
This should also be a lot shorter because there's a punchline and not as much digging as Jackie had to do. So Jen, you might have seen that already on your review, so I would agree.
And I heard Tree just give you the fist sign.
That's always like the introjected super ego. It's always in my mind. Yeah.
Okay, let's go ahead, Dr. Cruz and Varkey.
Thank you. So I'm Alejandro Cruz. I just finished my fellowship with Dr. Froman and Tree Froman at UT Austin, and Thomas was actually very involved also in this case. That's why we decided to present together. Thomas is one of our medical students at UT Dell in Austin. It is a more straightforward case, so I think the diagnosis is, I won't say it's straightforward, but I think it's definitely like straightforward compared to his previous presentation, which was great. We wanted to kind of just basically go over mostly like the symptoms, the clinical syndrome that this patient had, which I think is kind of worth reviewing. Thomas, can you please move? Thank you. So this was a 34-year-old patient. She was right-handed. She was actually a very functional lady. She was an attorney. She did have some past medical history concerning for IBS. She has some depression, some anxiety. And she actually had how this all began was she actually developed optic neuritis, which on her left eye. This basically happened like a month prior of us seeing her at Dell. She developed basically painful vision loss. That it was the pain was worse with eye movement. She went to see her optometrist, which identified that there was an optic neuritis. She was actually seen by neuro-ophthalmology, who confirmed the diagnosis, and she was actually given 1,000 milligrams Solumedrol to address the optic neuritis. Next. While she was actually waiting to be seen at our MS center, that's when, while this was going on, there was some waiting that she was waiting for, like, I believe just like a couple of weeks. But kind of looking back, she said that she had been noticing some unexplained fatigue for probably the past 6 months or so. She had also kind of like looking back noticed that she had like some paresthesias, mostly in her legs, which she wasn't sure that if she had like true weakness or maybe it was the numbness. Sometimes it was getting like so bad that she felt that she was weak, but it was kind of like coming and going through the past years. So just because it was kind of self-resolving, she didn't think too much of it at that moment. Next. The reason she actually came to the ER before she had her appointment at the MS clinic, neuroimmunology clinic, is because she actually had some very peculiar symptoms. She actually, all of a sudden, she developed what she described as ringing in her ears, which kind of pinning it down, and we'll go over it more a little bit in a little bit. She had like high-pitched tinnitus. She also kind of described this having this fullness in her ears bilaterally, and she noted that overall her hearing was basically declining. She thought that maybe the left was kind of worse than the right. more interesting symptom I think she had, which again we're gonna go more in detail later on, is that she actually described what is known as polynacousis. So she actually had like a perseveration of sound while she was basically watching TV. And now I guess can we move to the next one? Okay, and she actually was watching a basketball game at home with her family, and then all of a sudden, basically they went to halftime, they timeout or something, and they mute the TV. She basically exit that room, and when she was walking, she was actually still hearing like basically the sports commentator in the TV. And, she didn't think too much of it, but when she came back, she saw that, what she was hearing was not what it was in the TV. And then she realized that the TV was muted. This is kind of, again, we'll go more into detail about what polynacousis is and what is discussed, but this was something that, of course, caught her attention. She got really worried, and in some with the other symptoms she was having, that what made her go to the ER. And I guess we can stop. Can you go back? So I think here we can stop, and I guess just pick somebody brings and see what are your thoughts about what this could be.
Yeah, it'd be great to have a couple fellows maybe first, and then a couple of our faculty weigh in on if this development of symptoms, hearing changes, polynacousis, if what it makes you think of in terms of what the patient has. Are we still correct in what we're thinking she might have? What are your thoughts about this particular symptom? So we'll go for volunteers on the fellows, or we'll maybe see if we can pick a few.
Yeah,
Don't make me start calling people.
Go for it, Doris. Call out. What is this?
Sometimes you can get it with a temporal lobe lesion.
Very good. Yeah.
Okay. Any other thoughts from fellows? And then I think we have Dr. Goodman, Dr. Zambol's on the call. We haven't heard from them yet, but any other fellows want to weigh in?
I know, at least when I think about like vision changes and hearing changes, you might think of something like Susak's, but I know that's more like hearing loss as opposed to polynacousis.
Excellent. Always good to remember that. Can be an overlapping demographic.
Although your point about loss is important, because there are people who have a sensory channel abnormality initially characterized as diminished or lost, and then secondarily can have what we call release phenomenology, like we know in the visual system with Charles-Bonnet syndrome. It also happens in the auditory channel and in others. So your point is well taken, depends on what phase you're in.
Yes.
Sorry, Jen.
Oh, no, that's okay. All right. Any other faculty we haven't heard from yet today? I see maybe Dr. Fox, Dr. Goodman, Dr. Zambol.
I only went as far as the two that were mentioned, and just thinking temporal lobe in Susak's. So have not experienced this.
And the only other thing I'll throw out there is sometimes when you inherit a patient who has optic neuritis, they didn't, it sounds like in this case it was really clear cut, but sometimes you just hear vision loss and you need to dig a little deeper to see if it was something more along the lines of a branch retinal artery occlusion like Susak's, or something even, as wild as something like Cogan syndrome, where they could have hearing loss and some vision changes, albeit not from an optic neuropathy. It sounds like in this case, though, the optic neuritis was pretty clear cut and evaluated by the neuro-ophthalmologist at Dell. Any other comments before we move?
I'll make one comment. This is Scott. Someone mentioned temporal lobe lesion. So when you have these positive symptoms that may be recurrent or intermittent, you always have to think of epilepsy, right? Because there are some strange epileptic syndromes that are out there. So I think that was really a nice comment about temporal lobe lesion.
You are quite right. And in MS patients, we rarely, you don't see as much visual loss. There's a lot, hearing loss. There's a lot of redundancy in the channels, and this might have been one of these perfect storms to produce this kind of phenomenology. It's never been, by the way, described in MS. It's been described in stroke and in hemorrhage and a variety of conditions, but not in demyelinating disease. And I'll just, I'll let them continue on as to what was the combination of factors that led to this perfect storm to produce this.
All right.
Yes, so and you know that those are great comments, and yes, those were all in our differential. I think other thing that probably is worth mentioning is like we know people that patients that have an autoimmune condition can have like more than one. So what that was also another thought. What if she had optic neuritis, right? It seemed that it was straight cut retrobulbar optic neuritis, was evaluated by neuro-ophthalmology, thought it was retrobulbar optic neuritis. What if maybe now she's having autoimmune inner ear disease, which it could be, right? I mean, that's another thing. But of course, like the polyneurosis maybe wouldn't kind of fit in there. So we'll go to our exam now. So in the initial examination, when she was evaluated by the neurology team, Adele, well, she did have a left relative afferent pupillary defect, and her optic nerve was pale on that left eye. Basically her strength was good. Her motor exam, good tone, really no sign of spasticity, but she did have hyperreflexia throughout the left side, her upper extremities and lower extremities. Romberg was present, and she also had appendicular ataxia bilaterally when basically checking both upper and lower extremities. And interestingly, I mean, we didn't have an audiology department available in the ER as an inpatient, in the inpatient, but we did the old-fashioned Weber and Rinet test, which actually, Weber test lateral actually show like in the left air conduction greater than bone conduction, and which kind of was pointing to neurosensory hearing loss. And we'll go over also this in a little bit more. The rest of the neurological examination actually was normal. Okay, so before we show the MRIs, I know normally this is we try to get imaging first sometimes, but I think it was worth here kind of also summarizing all of those ideas and comments that you all mentioned already. So we were trying to rule out if this is something like systemic effects in the CNS, right? So we kind of went over and the rheumatologic workup. She was checking for Sjogren's, got ANA, C-reactive protein. All of that was negative. ACE level was within normal limits. So we also, of course, thinking about if could this be autoimmune in ear disease. So we checked for anti-68KD antigen, which also was negative. Just because of optic neuritis, and we have now AQP4 cell-based assay really available. We also went ahead and tested that. I think MOC was also tested. I think you just didn't include in here, but both were negative. Infectious workup, Lyme. We do have some Lyme in Texas, not as much as in the north, but it does happen. But that was negative as well. And an autoimmune panel from Mayo also came back negative. Other infectious conditions like HSV, VCV, hepatitis, tuberculosis, HIV, all was negative. Her CSF, though, does show that she had 7 unique oligoclonal bands. Her protein was 30, and her IgE index was just mildly elevated. So I guess maybe here, before going to the MRIs, I don't know if anybody has any thoughts about what this is more looking like.
Why don't the fellows comment first, if you have any comment?
Yeah.
Well, I would just pick on them, because if they were in the room with the family and that's the fellow, they'd say, look, you're the doc, you're the fellow, what do you think? So pick on them.
That's right.
I get picked on all the time.
Maybe there's a few fellows we haven't heard from yet. If you're able to unmute and just say what your #1 diagnosis is.
And as I said, this is just a clue. This is kind of a straightforward diagnosis in a way.
Yes.
How about Dr.
Hi there,
Maldonado?
this is
Oh, go ahead.
this is Francisco Gomez. So looking at these labs and kind of the presentation, the fact that she has the oligoclonal bands, the IgG index is elevated, it would make me think a little bit more of something demyelinating or neuroinflammatory. So MS would be up there.
We love you. We love you. Clear thinking.
Yeah. Thank you. Yeah, so I move forward to the MRI.
Said with.
Okay, here it is. So this is the T2 flare, and you know, they're like basically throughout the brain, there were like T2 hyperintense lesions throughout the brain. We have some subcortical, we had periventricular. Probably I didn't show the best periventricular images here, but they were. But interestingly, I mean, if you can see here, and I'm gonna show it in the, can we move, well, I guess in the, in this one still, you can see that there's some lesion involving the temporal lobe. Now, if let's move to the next one. The post-CAT imaging, actually, interestingly, it showed that the left 8th nerve actually was enhancing. I don't know if you can appreciate it, but there was definitely some enhancement also that happened that kind of correlated with her symptoms. If we move to the next one, more MRIs. You know, throughout the brain, there were lesions that were enhancing with gadolinium. As you can see, these were involving both temporal lobes. They were like incomplete ring enhancement with gadolinium. We move to the next one. And so she had quite a bit of lesions, and we were kind of surprised to see the amount of kind of lesions of that she had been, that she had not been really very symptomatic until recently, but it seemed that she had like quite a bit of activity. We can move to the next one. So our diagnosis after doing all of this, and we kind of saw that it was relapsing brain multiple sclerosis, which, you know, presenting initially with optic neuritis and then auditory symptoms, which is something that kind of after seeing this patient, we went back to the literature, and we're going to go over that. Thomas actually did a really good job putting this together, but it's something that sometimes we don't talk that much. And it was interesting to see that you know, there's a lot of sensory neurohearing loss that are basically classified as idiopathic, but they really never get to see the neurologist, most of them, just because they're having just ear symptoms. So it kind of makes you wonder how many of these ended up or could end up being actually due to something like multiple sclerosis. We decided to treat her with Solomedrol 5 days. We also did plasma exchange. And again, this was right at the beginning. We didn't know what if we were treating it with MS or if it was, could this be also autoimmune ear disease? So that's why we decided to go ahead and do plasma exchange and also steroids kind of at the same time. Once we got the diagnosis and kind of we saw the degree of the degree of disease radiologically, and of course because she had already two senses affected, so she already had optic neuropathy, and now she was having hearing loss. So two of the senses were being affected. So we thought we needed to be aggressive in selecting the right disease-modifying therapy for her. So after consideration of a couple of therapies, we all decided to do alemtuzumab. Which, you know, we got her approved, and she got it and did really well initially. And we can go to the next one. Okay, and now Thomas is gonna take over as far as our review.
Can I ask a quick question?
Yes.
Just curious in hearing the discussion around like why alemtuzumab versus maybe some of the other high efficacy drugs. I think for those that are more junior on the line, it's sometimes challenging deciding which of the 20 or so therapies we're going to start patients on. And when you have someone with aggressive onset MS, certainly we do think about using a high efficacy drug. But I'm curious why alemtuzumab over, let's say, ocrelizumab or natalizumab. I didn't see JCV test, maybe I missed it, status. So just curious.
Yes, the JCV status was checked. She was positive. I don't remember the titer though. I think, I mean, we presented basically the options to her. And there were a couple of things that kind of motivate us and motivate her. I mean, one of the things that also we kind of like to, you know, get to know our patient, and she was a very anxious person going through a lot of basically social and family problems that have been causing her a lot of anxiety, depression. Now, a lot of her like of, and I'm quoting here, being on medication for the rest of my life, and you know, and also it was basically, so it was when we presented the medication. One of the things that stand up to her really fast was. And I don't think like Mavenclad was available at that specific moment yet. But one of the things like that she liked about being like an aggressive therapy that she didn't have to be on for the rest of her life. I remember vividly that that's kind of one of the things that she actually pushed forward a lot because of that. And the other thing is like just because in the alemtuzumab clinical trial, we saw that I blanking a little bit on the exact number, but I think it's up to 35-36% of the patients they have actually some improvement, objective improvement of their symptoms, which, you know, given her being a lawyer now, having difficulty with her vision and also with her hearing, we didn't know if this actually was gonna recover or not, which she eventually did, but it took some time to actually recover. We were trying to give her the best chance that she had to try or to see if she also had some improvement.
And sometimes people will use the up to 50% incidence of secondary autoimmunity associated with this drug as a militator against it. But in the 8 years during the trial and after the approval of the drug in December of 2014, we have never had a patient with secondary autoimmunity using our whack-a-mole B-cell depletion strategy, which was published in Neurology N2 last month. So you can take a look at that. And, you know, we've had, you know, data coming out about neurofilament, you know, biomarkers demonstrating that this is the agent that has the biggest delta after treatment intervention and also the lowest level stability-wise over time, even though, as Alex points out, they get cycle 1, cycle 2, and they may be done, even though you know, and all of us on the line know, some patients can get 3 cycles, 4 cycles, 5 cycles, but the majority of them will get their 5 and 3. So,
Dr.
Can
I think Dr.
Scott.
Goodman. Oh, and Scott, go ahead. I think Dr. Goodman, did you raise your hand?
Go,
I think.
go ahead, Dr. Goodman, and then me. I'm going to get the dogs to self-harming.
Yes. So interesting discussion, and I certainly understand the thought processes that Alejandro and I less understand Elliot's thought processes, but that's another story. I think it needs to be said, just needs to be mentioned that the FDA approved alemtuzumab as essentially a third-line therapy, and I think we just have to mention that what was chosen is not, you know, in line with the FDA's thinking.
And then Scott.
Can I add to that? Scott is going to underscore what Andy just said, and that is you've got 3 high efficacy drugs. You eliminated one, which is Tysabri, because of the JCV. You didn't know the titer, but I would just take it off because of that. But from, you know, March 27th, 2017, with the approval of ocrelizumab, I would say far and away that the fellows, I think, should just be aware that many centers, a majority, I would say, would choose this. We at UCS have probably not more than 6 patients total on alemtuzumab. granted, we're not doing the whack-a-mole approach, but just, and there's nothing wrong with using alemtuzumab other than the fact that it would be third line, but just the fellows should be aware that
Yeah, no, that's why I
there were some
asked the
unique
question.
aspects.
Yeah, no, that's why I asked the
Yep,
question,
thanks.
because it's very regional, it seems, at least in the mid-Atlantic area. We don't use a lot of alemtuzumab, but again, doesn't mean that you shouldn't consider that in the bucket of high efficacy. It just is one of those drugs that I think we're continuing to learn the full safety profile of it as more people are getting on it. And the whack-a-mole approach, Elliot, I mean, you know, that paper was beautiful. I think maybe we'll see less of that secondary autoimmunity with that approach. But it's not only the secondary autoimmunity that one has to worry about. You know, now we're learning about the strokes that are occurring, and probably a whole bunch of other things down the road, including infections. So
Thanks for bringing that. I was going to bring up stroke, and then it looks like Sarah Frederick has her hand up.
And we also have a comment in the comment box from Brigitte about how often do you see CN enhancement beyond trigeminal neuralgia in MS?
That's a good question.
For me, I will say I really don't know. But yeah.
So I would, let me point out one quick. If you look at, you can get the nerve enhancing even if the lesion is central. And the best example of that is West Nile virus, the anterior horn cell stuff reported by Jun Lee many years ago from Wayne, and Rich Lewis and a few others. And even with anterior horn cell, you can actually see the roots coming out, and they may enhance, and rather quickly. I would have thought it would have taken 14 to 21 days, you know, before you get Wallerian changes. But in a case that was presented at Grand Rounds Friday, last Friday at our place, Jun pointed out that you can see it rather quickly because you don't have to have the things starting to break down, and that nerve root will enhance. So if you want to make the eighth nerve, the root, as it were, coming out of the brainstem complex, although I didn't see any lesions in the brainstem, but it doesn't have to be very big if it's just a few nuclei. So
can I make a comment about that? And that is
that it could happen. Doesn't make, there's no reason not to expect that.
Yeah, Teresa and I published a paper in the Green Journal many, many years ago about vertigo in MS. And let's be clear, the most common cause is still benign paroxysmal positioning vertigo. But number two is an MS plaque. And the two common locations are either the eighth nerve at the entry zone, so it could be pontomedullary. And when it is often seen that the extraaxial component of the nerve exhibits enhancement. We know that a few of those myelin internodes are still internodes contributed by central oligodendrocytes. So the two most common zones, eighth nerve as it enters pontomedullary junction, and the second is medullary tegmentum. So some of those patients can mimic, for example, Wallenberg or partial lateral medullary, and we've published those. We did a systematic consecutive series. BPPV is one, two is plaque, and the two plaque areas are those two areas, and it's common for the eighth nerve to have extraaxial enhancement. And we have pictures of that in the paper. So Doris, I will
send that around. Yeah, send that around. Great
question, Doris. I will send it to you like we've done before and distribute it to everybody who's on tonight. About that. I will send it to you in a few.
And in the old Montefiore
good question.
Pathologically verified cases of MS, Merritt and Carter and Chiara and so forth, 7% of the patients, autopsy-proven MS, had vertigo as part of their first attack. So not common, but certainly occurs.
Right. Yeah. Okay. In the interest of time, you guys want to keep going so we can get to the end. I know you guys spent time putting this together, and it is the first case of this. So,
do we want to get to Sarah? She had raised her hand.
I'm sorry. Yes, please, Sarah.
And we don't have to have a long discussion about this, and I can even ask you, Thomas, what your experience has been at your center. I'm just curious. We did a lot of talking about alemtuzumab and what we think the future of that drug is going to be now that we have Mavenclad on the market. We haven't seen secondary autoimmunity with it. And most of my patients that I have prefer an oral to an infusion if possible. So I was just curious from really the other fellows at their centers and then some of the more seasoned people on the call, if you're seeing a change in the direction of prescribing.
I'm going to defer to Dr. Cruz. I've just been a medical student on the team for a while. I've seen the use of alemtuzumab, and I've seen the benefits, especially using the rituximab whack-a-mole approach that Dr. Froman recently published, and the benefits we've seen in several patients, including some improvement neurologically speaking, and then other cases of some other organ reconstitution. However, just based off of my understanding of the way patients interact, I would agree that oral is often perceived as better than the infusion, just because they have less of a requirement to come in, less of the sitting down and getting the injection. But I will have to defer to Dr. Cruz, as I've just been the medical student on the team.
This could be a whole probably hour conversation. So I think maybe if anybody has some burning thoughts, we do want to respond to it, but there probably are a lot of thoughts out there. I will say briefly that I have not used a whole lot of alemtuzumab either in Northern or Southern California, but I recently inherited some patients from closing practice with a lot of them on alemtuzumab, and almost every single one has Graves' thyroid disease. They did not do, a whack-a-mole or anything like that, but they do all have Graves' disease. And I would reiterate what Dr. Newsom said, that in addition to competition with orals, I mean, the data for alemtuzumab, have generally been strong, but the recent cases, I think, reported in 2018 of strokes in young people, both ischemic and hemorrhagic strokes in young people, definitely put a little bit of pause on the prescribing of alemtuzumab, and whether, maybe we want to take one or two comments here about whether people think that's more relevant or the competition is more relevant, but it certainly got a lot of more senior folks' attention to see those strokes.
Jen Boblisek, the other thing is there's been a couple of other rather bizarre diseases with it, including
HLH.
And also cholecystitis without gallstones.
Yeah, very
And
good.
I see Edward Fox, Dr. Fox is on the line. I've seen his name in many publications with alemtuzumab, so I'm just curious what your experience has been.
Raised his hand, so yeah.
Yep, the timing was perfect. I have been involved in early stage trials for both Mavenclad and Lemtrada, and I think that alemtuzumab and cladribine are remarkable drugs, but they do carry risks that are both known and unknown. I honestly believe that the whack-a-mole approach probably is going to get rid of a lot of the clotting problems that have been seen. I had several cases of DVT pulmonary emboli on patients that were treated, and they were spontaneous, so they were not induced by any obvious cause. And they did see hematologists and were found to have autoantibodies. And so I think that a lot of the odd phenomena are actually autoimmune, secondary autoimmunity. And so I do believe that we are probably underutilizing the drug, but having been there at the FDA when we had the advisory board, I understood the rationale for making it third line. And I have, in clinical practice, used it as third line.
Yeah.
But I have also kind of gone to bat for my patients where I one of the lines to be steroids. When they were not responding to steroids and did not have good recovery, then failure on one drug and aggressive disease, I have argued successfully many times that that still is third line in my mind. But anyway, getting on to where I put it in conjunction now with cladribine. Cladribine, I do not feel has data that is as compelling about long-term benefits. And the one thing that I really want to bring to everybody's attention is when you commit to this, which my patients who commit to these short course drugs are doing so often because they're in the United States on short-term visas. They want to get treated. They're going to be going home to elsewhere. They want to be cured in their mind. They're extremely aggressive at wanting to handle this. And now I have patients who are worried about losing their insurance status and not being able to get medications in the future and wanting to be treated while they can. So, I mean, there are motives that you have to listen to the patients. But the point I'm trying to make is that when you commit to the long-term treatment, you need to know you're going to have long-term follow-up where you're going to be able to assess their safety. And you have to be willing to get a lot of exams and MRIs because you do not want to play whack-a-mole with the disease. You don't want to wait for relapses and wait for breakthrough before you treat. And I have seen people get worse because they disappeared from sight from the clinical trials after the trials were ended. And they came back and they had accumulated disease and had breakthrough. So I could go on and on, obviously, but those were the major points that came to mind.
Well, Ed, I think you bring up a great point. The 6-year data post the core clinical trial, I mean, it's close to like 50% of people had breakthrough disease activity, right? So,
Yes.
So this is not a cure in any means. I mean, it's a high efficacy drug without a doubt. It works, but there's a large percentage of people that will have breakthrough disease activity. So I think your points are really well taken.
Thank you.
I won't take the last comment, but probably being the person on who's used the most of this drug, I have treated many patients with this drug and colleagues now all over the world doing it with the whack-a-mole protocol. And at least thus far, we've gone from 50% incidence, and Jen is quite right, the majority of these are thyroid, and it's more hyper than hypo. We have not had a single case of secondary autoimmunity, and I have never seen a drug produce the stabilization and improvement benefits, not just in relapsing early aggressive, but also in chronic patients. And again, I think there are a number, I would encourage people to take a look and take a read of that whack-a-mole paper. It wasn't just looking at a single outcome. We know that the B-cell hyperrepopulation is not just B cells, it's also CD20 T cells, which are instigator cells. We believe, perpetuate autoimmunity. And by virtue of whack-a-mole, it's not just mitigating secondary autoimmunity. This may be producing an immune deviation that allows the establishment of the Th17 to the regulatory ratio that looks more normal. So I'm just going to say this as a last point. Today's heretic is often tomorrow's pain in the ass, and the day after that is the field's standard of care. I'm going to predict that we're going to wake up in 5 years, and notwithstanding oral or otherwise, alemtuzumab will have a resurgence. By the way, I own no stock. I'm not involved in that. I think this is potentially, I believe, the most potent, capable, stabilizing drug, and to promote improvement if you deal with its other issue. And I think the low dose, timed, punctuated administration of low dose anti-CD20 therapy at the time of the B-cell hyperrepopulation, which you measure, you're not guessing like when you're giving, ocrelizumab. I believe this will be the agent. 5 and 3, and the majority of people will be done.
Great. Well,
so Elliot and Jen, it's Scott here. Can I one last comment, and that is to Elliot and 1+ for this medication. I think back from what I've learned from Pam McComb in Australia, who's probably the #1 prescriber there. And that is, if you're thinking about women and planned pregnancy, there probably isn't a better medication out there because of the 5+3 in terms of the, the interval.
Yeah.
In terms of treatment, it's a big advantage.
It's a great point. And by the way, we didn't want this to be about alemtuzumab. These are very important points, but I do want to let the boys finish because this is really about palinacusis, although these are great. And Jen, Scott, maybe we need to have an entire session on intensive cell depleter strategies in MS, the good, the bad, the ugly, and the X-file. I think we've all brought these things up. But I want to let the boys finish the palinacusis story. So go ahead, and I will not make any further comments.
Sensorineural hearing loss in multiple sclerosis occurs in roughly 25% of MS patients. Of those 25%, 92% of these occur in the early stages of the relapsing remitting MS and within these particular patients. And it's the presenting symptom in 43% of female patients. One of the problems, though, is that within the US, roughly 90% of sensorineural hearing losses are classified as idiopathic, just as Dr. Cruz mentioned earlier. And then they may or may not have follow-up with neurology, which might be a problem, as we might be missing several of these patients with MS for many years, and they may not get diagnosed early on, or they may not get diagnosed whatsoever and be lost entirely to follow-up. So as mentioned earlier, due to the fact that we didn't have audiology, we did the Rhine and Weber testing. And just to kind of bring this up, Rhine and Weber testing have very high sensitivity and specificity, with Rhine testing having anywhere from 43 to 91% sensitivity and anywhere from a 50 to 100% specificity. And for use of the 256 hertz fork, and it had roughly similar for a 512 hertz fork. And for the Weber testing, there's a sensitivity of 73.2 and a specificity of 100%. The Pearl is the biggest mistake is not using a 256 hertz fork or a 512 hertz fork, and using one of the ones that we would use for diabetic neuropathy testing. So make sure you're using the right tool for the right test.
Use the 512. The 256 should be banned. It doesn't do vibration well, and it doesn't do hearing well.
Totally agree. Totally agree. 128 and 512.
C below middle C and the C above middle C.
Okay. For palanecusis, it's an auditory phenomena that what happens is you get the environmental exposure, and so you're hearing a particular noise, and then this leads to a persistence or recurrence after that initial stimuli. The noise that first started stops. This is different from psychiatric auditory hallucinations. This is an illusion versus a hallucination, with illusions being caused by outside stimuli and hallucinations from internal stimuli. And it has been reported on patients with epilepsy, as mentioned earlier, malignancies, tumors, and other types of cancer that perhaps are invading that region, stroke, trauma, and infection, of course, such as VZV or HSV encephalopathies involving the temporal lobe. So our etymological derivation, this comes from the Greek with palin, meaning again, and acusis, meaning hearing, literally hearing again. The thought process is it's a negative release phenomena from the loss of function of a normal little suppressor. So there's kind of a dampener within the circuitry. And so when you lose the dampener, you have the perseveration of the hearing as it goes around and around and around the circuitry, going in a little loop. So you hear it again and again and again. And as a result, there's that perseveration of that hearing. The case continues actually, and the patient developed palinopsia, so perseveration of vision, and it's usually stationary, but in this particular patient, she developed a kinetic palinopsia. She'd been chasing around her demented neighbor who walked into her front door, sat on her couch, urinated. She chased him around outside and was trying to get him. And she was chasing around in 100-degree weather for 2 hours. And she comes inside, she was trying to cool off and turns on her ceiling fan. And she stares at her ceiling fan and she sees this perseveration of the spinning ceiling fan. It brings up a question, is this any number of things, right? Is this an Uthoff's phenomenon? And she's stressed out, she's overheated, but she never really experienced this kinetic palinopsia before. Is this a brand new MS attack? And do we need to get an MRI? She had that old case of the left-sided optic neuritis. Maybe are we seeing something as a result of the older lesion? And Moore's lightning strikes, which can happen when the patient lays down in bed and looks around and they see these little flashing lights, but it didn't sound like that. So kind of a question of what this might be. We will provide more data and probably do like a part 2 of this when we actually have all the details. We're currently waiting on further data from the provider over at the UT Southwestern. And one of the most interesting findings was a positive McArdle sign. Now, unsure about everyone on the call if they got a chance to read the Mayo Clinic paper on this, but McArdle sign and Lhermitte's are both very interesting things that have come up. So Lhermitte's sign, of course, is the flexion of the neck, which then leads to this electric-like shock running down the spine, or a pain like running down the spine, or maybe a pulsatile vibration. There's any number of things. And there's also been some deviations along that with it going up into the occipital region, or perhaps down the arm or down the leg, or having some of these other ones. But the classical Lhermitte's that was described is the flexion of the cervical region with the running down electric shock or chill down the spine. McArdle's sign is a mixture of Lhermitte's plus another finding. And this is where you go ahead and you flex the neck. Both before you flex the neck, you test the patient's extension of the wrist, and then you have them flex the neck and watch for signs of weakness in the extension of the wrist. We will go ahead and forward the original paper to you so you can go ahead and take a look at this. It has a very high sensitivity and specificity, very high that, from my knowledge, I think the only thing more sensitive and specific is the actual MRI. So we'll send that to you so you can take a look.
Listen, I also wanted to let you guys know in the case of this kinetic palinopsia that was going on, she had evidence of a new right insular and subinsular white matter hyperintensity without gadolinium enhancement. So there is another, it's a new lesion, but we don't know the nature of that. It's under investigation. So we'll see what that turns out to be. And Doris, we'll send you the paper on both McArdle's and the paper on vertigo lesions in MS. So you'll have both of those for distribution.
Elliot, that's interesting. There was a new lesion, but you don't know when it occurred since you don't. Nope. So and it wasn't enhancing. So it still could be that relatively new lesion, we'll call it, then being triggered by an UTOF. And
Right.
one of the other things is, an air conditioner sometimes is cheaper than an MRI scan. But people who want to read about UTOFs and Lhermitte's, why and how it occurs, there are two classic papers. I think they're both in Brain. One goes so far back that I think Ian McDonald, when he did it, was Fierce Fellow. Okay, so that's even older than me. They did an interesting experiment where they demyelinated the dorsal column of cats and ran in ringers, measured the conduction across, and changed the temperature continuously of ringers lactate, and showed slowing and then block, and then continued to cool it off, and it reversed. And then back in 78, when I was in London with Ian and also with Marty Raff, one of Ian's fellows did the same thing in which with a Lhermitte's. So they had a demyelinated lesion, and when they would flex the cat's neck, they got ephaptic transmission. Now, if you put in a grant to try to do these two classics, no one would give it to you because it's not molecular enough, but they're fabulous papers, fabulous papers.
And then Teresa and I, back in 2006, as you might remember, took patients with MS and intranuclear ophthalmoparesis and used a tube-line NASA perfusion suit and measured core temperature with an oral ingestible temperature probe and transabdominal telemetry, and demonstrated you only needed about 0.2 to 0.4 degrees centigrade to move from about 5 or 10 standard deviations of adduction slowing in the INO up 0.2 to 0.4 degrees. You could go up to 15, 20, or 25 standard deviations or a Z-score, and then return with cooling. So this was a nice, very quantitative way of demonstrating UTOFs and its reversibility. But what's important about it as well is if you were doing studies using this MLF pathway and wanted to show myelin repair and then resistance to UTOFs, you got to make sure you have the right lesion. If you have somebody who has axonal transection and you don't show slowing and then reversible velocity, you might basically buy a type 2 false negative error for a myelin repair strategy in the MLF. If you don't see this effect, you have to first demonstrate the bidirectionality of its pathophysiology. And we did some work on signatures on diffusion tensor, fractional anisotropy and mean diffusivity with Bob Fox at Cleveland, and showed as well that patients that have this reversibility have still relatively intact FA, which means their axons are intact, whereas those who don't may have more gliosis and less capability for myelin repair. So it wasn't just for interest's sake, it was really to try to dichotomize the pathophysiologic substrates. So when we pick patients for myelin repair strategies, we just don't put a hodgepodge of, yeah, that's MSI-NO, you're in. You got to know something about the underlying substrate so you know things about face and construct validity of your outcome.
Yeah, and just to comment on that, Elliot, with the phase 2 trials with anti-LINGO, in order to get into that study, you have to have very tight numbers as it relates to, DTI and MTR because of that particular reason that you just mentioned, the type 2 errors. And because if you're going to prove without a doubt that something has remyelinating properties, you want to make sure that you have the best technology to test it. So,
and you need a live healthy axon for the myelin to do something.
That's right.
That's right. Yep, great points. Okay, I would, Doris, I'll send you the papers, and then any other questions, Jen, Scott, about this?
Well, I just want to. Oh, go ahead, Jen.
I thought to wrap up that first of all, excellent job. Really important to highlight it. I think when I saw the slides with the frequency of having this symptom, it was certainly higher than what I thought based on my experience and practice. I think it's very interesting to say that 42% of women living with MS will develop some type of hearing. If you go back to the beginning of your case, Dr. Cruz, and think about, and you don't have to do the slides, that's okay, but just when you showed us enhancement of the nerve and you showed us new lesions and the temporal lobes, when you put it all together now, and for your benefit, for the benefit of the fellows, just to express yourself how you put this case together, tell us what you think neuroanatomically happened for her to have those symptoms while watching the game. And then second of all, how did she do in terms of the palinacousis with respect to the treatments that she got? Does she still get that symptom from time to time, or did you get that taken care of?
No, actually, that resolved completely. That resolved completely after. I think the plasma exchange was what did the most dramatic. Well, I mean, I guess who knows, right? But I mean, she got the steroids and the plasma exchange. But I think because there was a bit of delay during plasma exchange. So I think after she got like the third exchange, that's when kind of the symptom completely went away, and actually, to my knowledge, hasn't come back. As far as kind of localizing everything, well, I mean, she did have like temporal lobe lesions, which when we know that the primary auditory cortex, the primary I would say more than the cortex, the complex primary auditory complex is all embedded within the temporal lobe, I mean, between that and having also involvement of the 8th nerve, I mean, I think they must have basically created what we see, because palinacousis is mostly described in epilepsy, and specifically in temporal lobe epilepsy. So our thought was that this is kind of basically what happened. I mean, it goes like temporal lobe involvement, and the auditory integrated pathways were involved, and that's probably kind of what triggered the palinacousis.
And for the fellows, that inner bank of the superior temporal gyrus, not the outside, the inner bank, stick your finger in the Sylvian fissure and wrap your finger down a little bit. You're hugging Brodmann's area 41 of Heschel's gyrus, which is the acoustic stream target that I think Jen was looking for and that Alex is speaking about.
Excellent. Well,
that's fantastic.
Great job on both of our cases. I'm looking carefully at the time, so just want to compliment our two sets of presenters. Excellent discussion amongst the fellows and faculty. Scott, any other closing thoughts?
No, this has been fantastic. And Elliot, we will, at one of these webinars, do a high efficacy versus maybe modest efficacy and show some of the data and get people sort of involved in what they would do, and maybe do a sort of a case-based type presentation, so we can figure it out. Yep.
Yeah, and I want to congratulate Jen and Scott for this is the second edition under their leadership and direction, and the amount of discussion among fellows, faculty, much more balanced. So I think you guys have really enriched this program significantly. It's really been fabulous, and I've enjoyed it. I'm learning a lot, and I got to believe the fellows and the students are learning a lot as well. So congratulations. It's great having you.
Thank you.
Fabulous.
Thank you.
Great to have everyone involved.
Thank you all. I'll be posting the recording tomorrow.
Okay,
Good
I'll send you the papers right now, Doris.
Sounds great. Thank you.
Okay, great
you.
job, Thomas. Thank you, Thomas.
Thank you.
Good night. Thank you.
Right.